هسوي introduction دكتورة بعدين سوي جسد.
طيب اوكي خلاص عادي. I could present without pointer.
اوكي.
فإذا في يعني complications. اوكي.
ايه وين ما عندنا لا البوينتر ولا يو اس بي. Hello everyone. I would like to introduce our next speaker, Dr. Nadia Al-Angari. Dr. Nadia is the head of the prosthodontist division and a program director at the Saudi Board of Prosthodontist Residency Program and at King Abdulaziz Medical City, National Guard Health Affairs, Riyadh, Saudi Arabia. Dr. Al-Angari graduated from King Saud University, School of Dentistry, Riyadh, Saudi Arabia in 2007. She received both of her prosthodontist clinical certificate and master's in dentistry from Indiana University in 2014. She continued her education, receiving 2 fellowships in USA and Canada. Dr. Nadia is a member of the research committee at the International Association of Dental Research, Saudi Division representative. Dr. Al-Angari has a very long professional experiences in her field with 11 research published at different journals. She has been awarded recently in 2020 the award of the Outstanding Faculty Member of the KSAUHS. I would like to give a round of applause, and Dr. Al-Angari, the floor is yours. Thank you.
Thank you so much. Is this clear? Okay. Good afternoon, everyone. It is a pleasure to be here today. I do thank the organizing and scientific committee for their kind invitation and their warm hospitality. I come from Riyadh, Saudi Arabia, so a big welcome from there, and I hope that you have a chance to visit Saudi Arabia somewhere soon. Today I'm going to talk about aesthetics, but in a different aspect. So pretty much I'm not going to show you before and after pictures. I'm going to pretty much talk about some concepts that we may, as a clinician, forget during our routine dental practice. So pretty much aesthetics in a prosthodontic context is pretty much a concept that we need to understand whenever we're talking about patients in the clinic. So I would like to emphasize on some key points that we need to understand. And just to know that aesthetics is a very much complex and complicated procedure. We all know that our patients cannot be put all together in the same cosmetic framework. So you have to pretty much tailor and customize your patient aesthetic treatment plan according to your patient's need. We know that the physical attractiveness is pretty much about the face. And when we look at the face, Goldstein have mentioned that the eyes followed by the dental structure is what makes the face attractive. So having the dental structure as the second part in your face that causes attractiveness pretty much puts some kind of load on us as a clinicians. So the first key factor that I want to talk about is that social media has a huge impact on our patients. We know that social media is driving unrealistic smile expectations. So the amount of advertisement that is going on in the social media pretty much precipitates some kind of concerns and some kind of aesthetic requirements that the patient is seeking in our dental practice. And it is our part as dentists to pretty much educate our patients regarding these kind of unrealistic expectations. The second key point that I want to introduce is that orthodontic treatment now is becoming a norm. And having the orthodontic treatment as an adjunctive therapy during your procedure pretty much will make your life easy. Rather than going for aggressive preparations or trying to be heroic in terms of trying to prepare teeth, aligning teeth, trying to correct some malocclusions, pretty much will be a little bit aggressive in terms of being a solo practice. So using an adjunctive therapy like orthodontics will make your treatment easier, more predictable, and conservative in terms of not being aggressive in your preparations. The third key point that I'm going to talk about is now age is not a limit. So no more numbers are guarding or concerning our aesthetic treatment plan. So 70 is the new 50. So when defining the new geriatric scale, they have seen that the new classification that patients above the age of 60 are considered middle age group. So looking at numbers per se is not, let's say, ideal in your proper treatment planning. So what I think personally is that if you're going to plan your case, look at the healthiness of your patient and fit. Sometimes you could find a patient that is 20 years old, has a lot of medical conditions. The patient cannot be compliant in your care. So pretty much this is a debilitating patient, whereas you could find, on the other hand, a patient that is 65 or 70, that is fit, is willing to come to your appointment and compliant. So pretty much age is not a number. Age is pretty much about the fit and healthiness of your patient. The fourth factor is that patients are being very demanding on immediate treatment. And this leads us to the previous point, or the first point, is that the social media has a huge impact on that. So pretty much the huge advertisement on a one-day procedure, one-day implant, one-day prosthesis is not pretty much realistic. And we need to be aware that all patients cannot be fit in the same category. So if you see a patient that needs a tremendous adjunctive therapy or multidisciplinary therapy, then you need to put in mind that immediate treatment will not be the ideal choice for that patient. So explaining to the patient why you're extending the treatment, why you're doing a treatment that will need a couple of months, pretty much will put trust in that patient. Instead, you could tell your patient that I could provide you with a temporary that has a good aesthetic results that will last with you during the course of your treatment. The last key factor that I'm going to talk about is we need to incorporate artificial intelligence and digital dentistry in our consultations. So the digital technology was introduced basically in the 1980s. And since that time, it was an option, whether you want to go in the conventional way or using the digital technology. But nowadays, with the increased science and technology digitally, you need to cope up with these kind of strategies. So if your office is not offering anymore any kind of digital technology, you're kind of way behind during the practice. So not using only the digital dentistry is a part of being barbing about your office or practice. It is pretty much you could show patients instant results. You could show your patient why you're selling your product or why do you need 3 to 6 months for treatment. So pretty much is augmenting your treatment plan, your explanation, and pretty much it will ease what's going to happen during the course of your treatment. The interesting thing is that we no longer call aesthetic dentistry as cosmetic dentistry only. There is a new terminology that is called the interdisciplinary activity of dental medicine. And I think that this broad terminology is pretty much accurate because we are augmenting different kind of dental specialties in aesthetics. So looking at doing some kind of perio treatments, ortho treatments, sometimes you need endodontic treatments, so pretty much you're working with dental medicine rather than working with only cosmetics. The important thing is that science is catching up, so you need to be pretty much alert about what's going on in aesthetic dentistry in terms of techniques, procedures, in terms of long-term studies, in terms of material, technology. So it's not about you being in your own comfort zone and trying to master only what you have. You have to be open up, you have to understand your limitation, you have to understand what you can do and what you can't do, and always, always seek advice and consultation. So I would like to explain the aesthetic dentistry milestone, and pretty much it is talking about, I'm going to talk about two components actually. I'm going to talk about the concepts that were advocated in the early 20th century, and I'm going to talk about also the materials that had been introduced during that time. So when we talk about the milestone regarding the techniques and guidelines, we see that the first concepts were introduced in early 1920s was the facial aesthetics. And pretty much, as we have mentioned, that the face is the attractive physical part of your body. So they have talked about facial aesthetics, they have addressed that facial aesthetics is important, and they have seen that what customize your facial aesthetic is the color of your teeth. So they have advocated the color and shade by Clark and Gill. After that, we have seen that aesthetic dentures were introduced by Pound. And why did I mention aesthetic dentures? Because aesthetics in dentures is the basis for our aesthetics in the fixed prosthodontics. So without the concepts that were introduced in complete dentures, we never know what's going on in fixed prosthesis. So these concepts were introduced and followed then by the concepts of Fresh and Fisher, where he tried to augment the aesthetics and cosmetics of complete dentures with the patient's personality, attitude, and sex. And he tried to see that our patients are edentulous. So how could we select teeth that could fit our patient personality and age? So rather than just fitting teeth without augmenting it with your own patient's attitude, then pretty much you're not going anywhere in aesthetics. So his concept talked about choosing or selecting teeth according to the patient age, sex, and personality, and how to customize the teeth shape according to your patient. Then smile line have been introduced, and the golden proportion. And as you all know, the golden proportion is a metric scale. So pretty much it is subjective in terms of proportions and guidelines. Nowadays, we're not using the golden proportion when we're selecting any kind of designs for our patient, simply because you are putting all patients in the same framework. So you need to be a little bit open up that we are getting away from the subjective component of our aesthetics and trying to go to the other scale, which is the objective part. After that, the introduction of the digital smile analysis and the digital smile design, so the digital technology, were rapidly introduced at that time. When we're looking at the milestone of the dental material, we see again, dentures are leading the material selection. So acrylic dentures were introduced, and we could see that after that, Buonocore advocated the enamel etching and the dentin bonding. Followed by the introduction of porcelain fused to metal. So they were thinking about materials that will restore missing teeth or prepare teeth, and will have a metal substructure that will reinforce the whitish appearance of the feldspathic porcelain. After that, they have seen that the metal substructure caused some kind of grayish stain. So they started introducing the jacket crown, so eliminating the metal component in those prostheses, and the introduction of the Bis-Gemma composites. Then again, the introduction of the CAD/CAM technologies in the 1980s, the bleaching, veneers, the resin bonded, so they're being more aesthetically aware or cosmetically aware about the patient's need. Then the introduction of the CAD/CAM technology, ceramics in terms of lithium disilicates and zirconias. And they have seen that zirconia per se is not an aesthetic material. So they were trying to work on finding a material that could give the same aesthetics and translucency as lithium disilicate. So they introduced the layered zirconia and then the translucent zirconia, and they're still working on having the 5YTP zirconia that has the highest translucency. And still the literature is working on finding a material that could mimic the strength of zirconia and the aesthetic appearances of lithium disilicate. It is important, after understanding all these parameters, that we need to understand the classification of appearance and aesthetics. And we always, or the majority, when they're planning aesthetic cases, they're looking only inside the patient's mouth. And we need to understand that we have three classifications of appearance and aesthetics. We have what we call the macroaesthetics, the mini aesthetics, and the micro aesthetics. So we have the bigger picture, the concise picture, and the inner picture of the facial attractiveness. So when we're talking about the macroaesthetics, pretty much we are looking at the outer picture. It is the same concept as Fresh and Fisher, so you're looking at your patient itself. So you have your profile, the vertical proportions, horizontal proportions, the nasolabial projections, and pretty much the lip fullness. This is a study that is shifting from the subjective criteria of the aesthetic parameters and going more towards the objective criteria. So what is the objective criteria? It's pretty much looking at the patient's ideas and patient concerns. What does the patient exactly want? So this is being subjective, and this study was done by giving a patient a survey. They have a couple of pictures that have presented to the patient, and then they have listed the factors that are either ideal, average, or below average that constitute with the macroaesthetics. So they have seen that the facial form accounted for the highest percentage in the ideal factors that contribute to macroaesthetics. Whereas the average factors, we could see that the horizontal proportion and the vertical proportion scored average. And when looking at below average, they have scored the lip fullness as a below average factor. And when we augment that with our understanding or science as clinicians, we always look at the lip fullness, although that the patient is not really concerned about lip fullness in this study. So putting the study just to emphasize that you need to look for evidence in your culture or society or country that will give you a background about your patient culture. What does your patient want? What does your patient not want? You could even have a survey that you could initiate in your office, and you could ask patient about whatever criteria that you think could have a huge impact or role in cosmetic dentistry. When we talk about mini aesthetics, we are talking about pretty much the smile. So we're looking at the incisor display, we're looking at the transverse smile, the smile arc, the smile symmetry, and the alignment or crowding of teeth. And in the same study, they have also listed the factors that influence the ideal factors, and surprisingly, they are looking for ideal teeth alignment as a huge factor that influenced the ideal mini aesthetics. Whereas it was followed by the smile symmetry and the smile arc. Whereas the average factors and the below average factors, we could see that both incisal display played a role in an average and below average. So if we go back again, we see as clinicians, we always look at how much teeth are showing when the patient is smiling. So when concentrating on factors that are really not that much concerning the patient, you need to step back, think, how should I plan my case to follow my patient perception? The microaesthetics, pretty much we're going more deeper inside the patient's mouth. So we are looking on fine details related to the soft and hard tissue structure. So we're talking about the gingival shape and contour, embragures, papilla, tooth shape, tooth color, and so forth. So this is the time that we need to go deeply inside the patient's mouth and characterize these factors. So it doesn't go one part at a time. You have to go in systematic sequence. So you have to look at the bigger picture and then a little bit smaller and then smaller until you go inside the patient's oral cavity. So in the same study, the tooth shade or color have scored the highest in the ideal factors, followed by the incisal embragure as an average factor, and the gingival height of contour as a below average. And again, I don't blame patient if they're not really concerned about the gingival contour, but we as the dentists look at the gingival contour, the zenith, the lines, and all that stuff. But again, I think we need to put a clear demarcation line between the gingival height of contour and a gummy smile. So understanding whether the patient is really concerned about these soft tissue landmarks is really important. So we know that when we're working with anterior aesthetics, we definitely have a risk when treating those patients, and pretty much I always consider cosmetic treatment is a high-risk treatment. Why? Because the patient are not the same. The patient have different expectations. The patient have different backgrounds, different culture, different education, different awareness, and different perception. So I have put here 8 photos for patients with a missing central or lateral incisor. And the purpose of that, I just want you to see that although they have a missing anterior tooth, they don't have the same micro or mini aesthetics. So you could see that we have differences in the lip fullness, we have differences in the smile arc, in the symmetry, in the size of the teeth, the shape of the teeth, the color of the teeth, and so forth. So you cannot put all your patient in the same cosmetic framework. You have to tailor your treatment plan, and you have to customize your treatment plan according to your patient need. So one part important during the course of your treatment is that you do an examination and analysis. Pretty much the prosthodontic treatment is not a difficult procedure. Preparing teeth, cutting teeth, taking impression is not that difficult. But doing a good diagnosis and treatment plan will make your life easy. So it is really important to shift towards a patient-centered outcome. So we're not anymore looking at your feelings or your perception about aesthetics, or looking at what does literature say about the guidelines of aesthetics. No, it is more towards a patient-centered outcome. So you're shifting the ball from a subjective outcome to a more objective outcome. And pretty much working with subjective outcomes led to an evidence-based literature that talks about why the patient did not accept this cosmetic treatment, although that we have done all the guidelines related to cosmetics. So this is an example of one of the articles. This article was done by a group of orthodontists. So they talk about lay people's perceptions of frontal smile aesthetics, a systematic review. In this study, they have talked about different smile criteria. So they talked about diastema, they talked about the gingival proportion, they talked about teeth color, they talked about teeth position, they talked about teeth shade, and so forth. So one of the things that attracted me in this article is that we always thought that if the patient had a diastema, the patient will not really be concerned about the diastema if it's not really showing. And surprisingly, they have seen that the patient could notice up to 0.7 millimeter of diastema. And the preferences of patient was 0% diastema. On the other hand, when they talked about the midline, we always remember the photo of Tom Cruise with the midline shift of 4 millimeter. And we said that lay people cannot distinguish a midline shift if it's less than 4 millimeter. Surprisingly, in the study, they have seen that the patient could detect as minimum as 1.8 millimeter of midline shift and a maximum of 2.8 millimeter of midline shift. So there are no more lay people. There are people that are pretty much critical about their aesthetics, and they're looking towards having a cosmetic appearance. I do think that the majority of you have faced a patient in the clinic that is pretty much picky about their aesthetics. And whenever you deliver any kind of prosthesis, they'll try to point out that I see this and I see that, and why did you do this and why did you do that? So this explains that those people are no more lay people anymore. They see, they look, they're open-minded, they hear, and they're pretty much attracted to social media. This is another study on the prosthodontic spectrum talking about the lay preferences for dentogingival aesthetic parameters, and it talked pretty much more concisely about the sizes of the central incisors, the crown to width height, the relation of central incisor to lateral incisor, the incisor edge, and so forth. So surprisingly in the study, the patients talked about the relation of lateral incisor to central incisor in terms of the vertical height. And they seen that the patient preferred the lateral incisor to be shorter than the central incisor, between 1 millimeter and 2 millimeter, or 1.1 up to 2 millimeter. And the highest scale, which is the 2 millimeter, was from the male section, whereas the 1.1 was towards the female section. So patients do understand how teeth look like. They also have seen that a pointed canine is ugly, a long canine is ugly. They also have seen that the central incisors should lie on the lower lip. So again, there are no lay people anymore. There are lay people with an open insight toward cosmetic and aesthetic dentistry. When we're talking about treatment approaches, I do like always to emphasize that we need to go always with the more conservative to the less conservative approach. And you could achieve aesthetic results with conservative approach. So the first thing that I like to do at the beginning is to advocate bleaching for my patient, especially if the patient has a stable occlusion and the patient has lined teeth or a mild crowding. Sometimes the patient come to you seeking Hollywood smile or veneers, and they cannot understand that there is a less aggressive option, which is bleaching, that could give you a brighter smile with your own characteristics, whether you have a little bit of a crowding or malalignment and so forth. So when the patient sees themselves with brighter teeth, they change or shift their minds that they don't want to do veneers anymore, and they're happy with their smile. So it is part of our job to treatment plan and diagnose those patients and to offer conservative options if they are practical in the case. Going a little bit to the next spectrum, the prepless veneers. Presenly, I don't do them, but they are one of the valid treatment options that are done. You have to be very careful when you're selecting cases for prepless veneers. Be away from skeletal class 2, be away from protrusion. Most probably you could use them for patients with small teeth, pig laterals, or spacing and some syndromes. It will help, but you have to be very careful in terms of bonding. Next in line are veneers. Veneers are a predictable outcome, and they have good aesthetic results and excellent durability. And unfortunately, I hear patients talking about their dentist giving them evidence on veneers in an opposite way. So they always ask me, do I need to replace veneers after 10 years? And I tell them, no, you don't have to replace veneers after 10 years. The article says that the success rate of ceramic veneers could reach up to 92% within 10 years, but it doesn't say that you have to replace them. The only time that you need to replace those veneers, whether there is any recurrent caries, any problems, any trauma, anything that you need to replace those veneers. Other than that, if they are done in a good way and you understand what you're doing exactly, they could last lifelong. Could we achieve aesthetics with fixed dental prosthesis? Yes, we could do. So fixed dental prosthesis is one of the predictable treatment outcomes, and you could change an ugly fixed dental prosthesis to a good one by careful selection, selection of patient, selection of material, and pretty much knowing exactly how you could change this. So if you see this picture here, just changing the contact area, broadening the contact area, you give an illusion that the papilla is squeezed. Whereas when you have a short contact area, the papilla looks that the embrasure is not filled and you have a black triangle. Also, selecting the correct material in terms of translucency will also give you good aesthetic results. So there is a good article that talked about, Yang et al. Talked about giving a patient a well-fabricated provisional. And this provisional pretty much is having an ovate pontic. So we have learned or have heard that whenever you have an extraction, don't place any temporary FDP touching the tissue. You're afraid of tissue shrinkage or you're afraid of bone deficiency. Surprisingly, in the study, it was published in 2019, Yang et al. Documented a case that he have followed up for a single central incisor that he have extracted, and he have temporized with an ovate pontic. He have taken records for the patient during the treatment and during the follow-up. So he followed up the patient after the extraction and 1 week after, 3 months and 6 months. So he took a CBCT for the case before extraction and during the follow-up period. And you could appreciate that during the follow-up period, the amount of thickness of soft tissue in the buccal area is the same. Despite that, he have placed an ovate pontic on the patient's tissue. When looking deeply into the CBCT, we could see that this is the CBCT prior to extraction, and then after the placement of the ovate pontic, and you could see the height of bone in the buccal area did not lose that much. So he concluded that using a provisional restoration with ovate pontic after tooth extraction may preserve the alveolar ridge by sustaining the soft tissue. So pretty much we're talking about the gingival papilla. Could we relate to his evidence? We may consider it. But his study is not a long-term follow-up, so he followed up for 6 months. But I think it's worth to investigate. And pretty much this is what I was saying, that evidence and science are moving fast in aesthetic dentistry. So you need to catch up evidence, and you need to be pretty much critique in terms of understanding which evidence you're going to take and leave. Going to more aggressive option, we have the implants. So implants could be a valid treatment option in aesthetics, and still you could achieve good aesthetic results with implants. So if you are planning implants, it is really important that you understand that you, as a prosthodontist or a restorative dentist, you're the first gate that the patient will seek and the surgeon will follow. So you need to prosthetically plan your case and go in a prosthetically driven manner. Now they're talking about a facially driven manner, so you're not only working prosthetically, you're working with the whole face itself. So you're planning the case from the face to the mouth, as we have mentioned, from the macro aesthetics up to the micro aesthetics. So one of the soft tissue scores that you could use when planning implants is the pink aesthetic score. The pink aesthetic score mainly looks at the soft tissue part, And you're looking at basically 5 factors. So you're looking at the mesial papilla, the distal papilla, the gingival contour, the gingival texture, and the gingival color. And looking at that, it is like a score, so you check whatever falls in your patient, and there's a specific calculation that you do with a number, and it will tell you that this number falls in which category. So whether your patient is a high-risk patient, a medium-risk patient, or a low-risk patient. And according to that, you could finalize your treatment plan. On the other hand, they have seen that only using the pink aesthetic score is not enough. And the hard tissue or the tooth plays an important role in positioning the implant. So they advocated the white aesthetic score. So pretty much we're looking basically on the tooth itself. So the tooth shape, the tooth color, the tooth contour, the tooth texture, and so forth. So augmenting the pink aesthetic score with the white aesthetic score will give you good results when you're executing implant treatments. So regardless what kind of scores that you're using, if you go back to the literature, you're going to find more than 10 scores related to planning implant in the anterior area. Despite which score that you're using, the important thing is that you need to think that I need to plan my case according to the existing situation. Missing one factor inside the patient's mouth, especially in anterior implants, could cause a dramatic change. As you have seen the cases of Dr. Khan, he have mentioned lots of efforts that he have done in his cases, and despite that, some cases have failed. So putting in mind that you're working haphazardly will pretty much give you the other way around, and you could get a failed aesthetics from the beginning. So tissues are delicate, tissues are not really bearing too much surgery. So you have to make sure that you work accurately, you discuss it and have good communication with your periodontist or implantologist or oral surgeon, and you give the tissue time to heal. Anterior area is not forgiving. So you need to give time for healing. And it's really important to explain to your patient that sometimes the treatment could last from 6 months and above. So don't rush in anterior area. Try to fabricate a well aesthetic temporaries, but don't rush the final results because tissues still take time to mature and heal. So this is showing the combined PES, WS scores, and you could use that when you're planning your cases. And according to that, you could either select your final prosthesis shape, whether you're going to go for a cement retained or screw retained, whether you're going to use lithium disilicator zirconia, titanium abutment, zirconium abutment, and so forth. Sometimes we go with combined treatments as prosthodontists, so we do in the same case veneers, crowns, implants, FDPs, and so forth, depending on the case itself. So it is a valid option. The only trick or tip that I will tell you, that take one impression for all your teeth. Don't take segmented impressions because the buildup of teeth, the shape of teeth, the buildup of your aesthetics in terms of translucency, especially if you're augmenting zirconia with lithium disilicate. So if you're having different materials inside the patient's mouth, let's say you have posterior material that is different than your anterior material, then pretty much you need to have a one impression that will give you a good buildup of your teeth shape and selection of material for your shade. Sometimes we go with a multidisciplinary approach, and this is really important that sometimes we need to be patient with our patients. So don't rush cases. The cases that you feel that need adjunctive therapy like perio or ortho, kindly do that. It will give you stable results. It will give you better control on the case and good aesthetic outcomes. Sometimes you are faced with cases that are not ideal, and we end up with some scenarios that you need to replace the soft tissue, not only the hard tissue. So when we're replacing the soft tissue, we're thinking about pink, whether it is a pink porcelain or pink composites and so forth. So in these cases, sometimes when you lack bone and the patient is going through multiple surgeries before and nothing worked, and the patient doesn't want to go for more surgeries, then expecting that this patient will have a soft tissue replacement should be part of your treatment. So this should be acknowledged during your treatment plan phase, and not when your technician tells you that you need to build up pink porcelain on your teeth. So this will help you in figuring out whether do you need to do correction of the gingival contour of the adjacent teeth, whether you need to do something else that will help in the aesthetic outcome. So when we talk about pink in general, we have the pink composites with different shades. So you select the shade according to your patient, and this is pretty much if you have teeth that are pretty much receded or there's any kind of defect happening and you want to change the tooth shape from a very long tooth to the tooth with a pink composite. So you still have different shades that you could select from. You have pink ceramics that you could select for your ceramics, and you also have pink acrylics that you could use for your removable prosthesis. So could we achieve any aesthetics in our removable prosthesis? Definitely we can. So whether you're doing a complete denture or you're doing a removable partial denture, still you could achieve aesthetic results with your patient. So complete dentures have specific acrylics that could be processed with different shades. So it is not necessarily that you give your patient a shade that does not fit the patient gingiva or the patient's skin color. So you have different shades that you could use, ranging from the darkest to the lightest, and we have the transparent one for using as a radiographic guide. Material selection is really important, so don't generalize materials for every patient. Sometimes you end up using zirconia, especially if you have cast post and core, especially if you have a patient that presented to you with a previous treatment and you're changing the treatment. Sometimes you could layer the cast post and core with a thin layer of zinc phosphate cement. It will act as an opaquer, it will block the color of the metal, and it could help you in selecting the final shade of your prosthesis. So depending on the case, whether you have a fiber post, cast post, discolored teeth, you have to select the material that suits the case. When talking about lithium disilicate, we have different translucencies and opaqueness of lithium disilicate. So when you look at the manufacturer, there is the medium translucency, the MT, the high translucency, HT, the medium opacity, MO, and so forth. Nonetheless, you also have cements with different color. So if you select the correct shade from the beginning, you're going to end up with a translucent cement. If you feel that you need to do more correction, then pretty much you have different shades that you could select for your final prosthesis. Augmenting different materials in the same mouth is normal. The most important thing is that you know how to match the shade, and pretty much we always recommend that you look into the evidence where exactly to stop putting ceramics in posterior teeth, when to put zirconia, when to mix and match between them. Never ever we have veneers from zirconia, and we all know what's the reason behind that. For different reasons regarding the surface treatment, the bonding, and so forth. So if you have a veneer, it's either you're going to have a feldspathic porcelain or a lithium disilicate. Whereas if you're going to go for FDPs or crowns, you have lithium disilicate and you have zirconia. Sometimes you need to repair an FDP at the time of try-in. So you seated the FDP and you discovered, or the crown, and you discovered that there's a small open margin in the proximal area or open contact that you need to correct. So you're going to send it to your technician to add a low-fusing porcelain. So understanding the material that you have, understanding your capabilities, and understanding your patient exactly and the patient perception will end exactly in a good aesthetic results. We all know that the anterior region is one of the complicated regions in terms of selection because light passes through, and you want to make sure that your patient is receiving a good aesthetic result. So take your time, try the temporaries, duplicate the temporaries if they're good. Look always about the phonetics of your patient. If you feel that the patient or the case is mixed up, always consult. Always take your time when you're doing your treatment planning and read. It is never too late to go back and think about your options, but whenever you start cutting teeth, it's an irreversible process. So it's easy to take your time before that, treatment plan, do your homework, and then it is after that an easy part to cut teeth and take impressions and cement. My take-home message for today is treatment plan, and treatment plan, and always work in a systematic approach in your treatment planning. Change or shift from a subjective outcome to a more objective outcome, more towards a patient-centered outcome, more towards evidence-based. Think that science is revolving fast, technology is going fast. You have to be updated towards this kind of technologies. Always work in a team approach. Don't try to just execute cases fast. They always will lead to dramatic failures. Be with your periodontist, endodontist, your orthodontist. Try to execute the case in the least aggressive approach as possible. I don't believe in correcting teeth with aggressive preparedness of teeth or preparation of teeth. We always think about the forces, the axial inclinations. We have roots inside the bone that not necessarily will go with how you have prepared teeth. So it's really important that you be very kind with teeth, be conservative in whatever approach you could do, work with a multidisciplinary team as much as possible, and always think that your treatment should last forever with no changes, with a long-term prognosis, and an acceptable aesthetic results. These are my references if you are interested in looking at those. And I do thank the organizing and scientific committee for their kind invitation and their great hospitality. And I'm happy to be here presenting in front of you guys and catching up with old friends. And thank you.
Thank you. Thank you very much for an outstanding presentation. The floor is open for discussion and questions. Actually, I have a question of my own. Regarding your multidisciplinary approaches, how often you find your acceptance rates with the patient when you have ortho components? How often do they accept the your patient acceptance rate?
Actually, I feel that the patient are always vulnerable. And patient always think that whatever information they get from social media is enough for them to decide what treatment plan they need to go for. So if you're confident about your practice and the patient understands in simple words why you're sending the patient for ortho, they're definitely going to accept. I never ever have faced a patient that rejected an adjunctive treatment, but they need an effort to explain. So you have to explain to them why are you sending them for this adjunctive treatment and give the patient the option. So tell them that I could do it in this way and we could do it in a more easiest way, a more harmonious way, and we could achieve a good soft tissue result, we could achieve a good alignment, and maybe you don't need to cut teeth. You're just fine with bleaching or a single implant. So if patient understands your reason, they're going to appreciate it.
A second question regarding your anterior aesthetic cases where you do crown lengthening. Do you wait the classic 6 months or you go earlier to restore?
I take my time. I never go early at all, especially for anterior area because the soft tissue maturation takes more time. They settle more, so they need time and the tissue is not forgiving. So give the tissue time, but the most important thing is the follow-up period. So also follow up your patient, change the temporaries if needed, but never ever rush time. Okay?
Thank you very much.
Thank you. Any other questions? Thank you so much.